Hello, welcome to the stream. I'm going to be seeing if everything is set up correctly, but probably just going to get straight started onto some Anki card review and just studying in general, just because I am needing to get some good studying done over the next few days. So hopefully if you guys join in, this will be helpful for you guys. For those of you guys who are tuning in afterwards, hopefully this is useful for you guys. We'll see how many questions we can get done this time. And how my correct ratio is, because last time I actually got like 12 out of 13 questions right, but that's kind of unusual for me. It's kind of hard to actually maintain a ratio like that, and sometimes I get a lot of questions wrong in a row, so we'll see how I do. But first I have my Anki that I'm going to do my Anki cards for first. You see I have 75 questions for the medicine deck right now. This is a little bit more than usual. Because I have, ASMR. Hey, what's up, Overkill? This is a little bit more than usual because I've been adding more cards recently. And let's get started on some Anki cards. Again, if you have any questions, let me know. So here we go. Some of these Anki cards are really old, so they're not super helpful. But anyways, does pregnancy improve symptoms of rheumatoid arthritis? The answer to that is yes. 2/3 of patients will go into remission or achieve low disease activity. 1/3 will not improve, or they will get worse. When titrating blood pressure meds, is it more effective to add a new agent or increase the dose of existing medications for optimal BP control? The answer to that is to add a new agent, because you get diminishing returns as you increase doses. For example, from amlodipine 5 to amlodipine 10, you're not really going to be getting as much benefit as if you just add like lisinopril or something else. The risk of causing DRESS with allopurinol is highest in patients with what two risk factors? That's going to be CKD and diuretic use. So definitely need to be cautious about using allopurinol in those patients. The major toxicity of mycophenolate is bone marrow suppression. So mycophenolate, bone marrow suppression. What is the treatment for severe carbon monoxide poisoning? The answer to that is hyperbaric oxygen therapy, which will oversaturate the O2 and basically help displace all the carbon monoxide that's binding to your hemoglobin. And the treatment for cyanide poisoning, on the other hand, is hydroxycobalamin. And I gotta fix this real quick. I just recently updated to the new Anki, and I actually really like how it looks. The way that you see things in the browse tab, like for example, if I look here, is a lot easier than it was before, because you can see all the cards, and then you can see like a really good amount of stuff on the right hand side, which I really like. So I do like the new updated Anki. Let's go back to some cards again. What is the treatment for... Let me make sure that the stream is live right now. Oh, it looks like it's live. Okay. Yeah, it looks like it is on. So what is the treatment for entamoeba histolytica abscess? The treatment for that is going to be metronidazole and paramomycin. Not percutaneous drainage or surgical resection, which are for pyogenic abscesses. Does prepatellar bursitis from frequent kneeling require drainage? The answer is yes. To rule out gout and septic arthritis, is active surveillance a treatment option for patients with very low risk of prostate cancer? Yes. So if somebody has very low risk, you can just kind of, low PSA, low grade PSA, architecture of the prostate cancer on biopsy, then you can just continue surveilling them with PSA and prostate biopsy as needed, instead of opting to start with treatment right away. Is Tylenol helpful for pain control in patients with osteoarthritis? The answer is no. Actually, multiple recent RCTs show no benefit, and basically you should be using NSAIDs instead. What is the next step in management if a patient misses greater than 2 weeks of their TB regimen? It should be restart from the beginning. If they missed less than 2 weeks, then continue the initial regimen until the planned total number of doses is taken. If it's greater than 2 weeks, then restart from the beginning. Contraindication for raloxifene is going to be VTE, or prior history of clots. just because it increases the risk. What is the etiology of periungual purpura? That's kind of purpura around the nail folds in patients with vasculitis. That's going to be thrombosis, nail fold thrombosis. Is chemical pleurodesis or mechanical pleurodesis via VATS more effective? That would be mechanical pleurodesis. So if somebody has secondary spontaneous pneumothorax, actually they should all be getting some kind of pleurodesis, but ideally it seems like mechanical works better than chemical. What physical exam maneuver is most sensitive for determining fall risk in patients with Parkinson's? That's going to be the pull test, where you pull backwards on the patient's shoulders, and is positive if the patient falls into the examiner's arms or takes more than 2 corrective steps. What is the difference between lacunar infarct and Charcot-Burchard aneurysms, despite both involving the lenticular striate arteries? Lacunar infarcts are going to be more ischemic, and these ones are more hemorrhagic, I believe. But I actually don't remember the answer to this question. Oh, so yeah, that's correct. So lacunar is more ischemic stroke. Charcot-Burchard is more hemorrhagic stroke. Can relapsing polychondritis cause a tender trachea and swollen joints? The answer is yes. I always typically associate it with the ear and kind of those like really inflamed ears that you see on exams, but I didn't know that it also causes inflamed trachea and joints as well. The triad of bilateral hilar adenopathy, arthritis, and erythema nodosum, that's going to be Lofgren's syndrome. For some reason, MixApp really likes this syndrome, and so it's patients with sarcoidosis, basically, who have arthritis and erythema nodosum, and this is very, very specific and sensitive for making the diagnosis. Very specific for making the diagnosis of sarcoidosis. You don't have to get a biopsy or anything after that. Is prolonged use of voriconazole associated with risk of skin cancer? The answer is yes, due to phototoxicity. What is a mnemonic for remembering the presentation of MEN syndromes? So there's 3 MEN syndromes, right? There's MEN 1, there's MEN 2A, and MEN 2B. So MEN 1 is going to be 3 Ps. So parathyroid, pheochromocytoma, pituitary, and then MEN 2A is 2 Ps and then 1 M. So it's parathyroid, pituitary, pheochromocytoma, and medullary thyroid. And then MEN 2B is 1 P and 2 Ms. So let's see. Pituitary, parathyroid, pancreatic, parathyroid, pheochromocytoma, and medullary. And then mucosal neuromas, medullary thyroid, and pheochromocytoma. What are the side effects of nicotine replacement therapy? That would be kind of like vivid dreams, nausea, local irritation. So you should warn patients before starting this. Will EPO levels be high or low in patients with polycythemia vera? If they have polycythemia vera from a primary cause, then it will be low. But if they had like sleep apnea and chronic hypoxemia that's contributing to their elevated hemoglobin, then it would be high. So in this case, it would be low. Palpable purpura involving the ears is suspicious for leukocytoclastic vasculitis from illicit drug use, specifically cocaine laced with a drug called levimisol. And so if you see that purpura in the ears, that's what you should be thinking of. Are patients with ESRD at an increased risk of developing RCC? The answer is yes. So it definitely becomes a higher risk of getting renal cell carcinoma if you have ESRD. So you got to be suspicious of any weird cysts or things that are appearing. What is the difference between a chi-square test and Fisher's exact test? These are both statistical things that we look for significance. Fisher's exact test is a smaller sample size, usually. Maculopapular rash over the extremities with central vesicles, bullae, and target appearance after administration of antibiotics. This is going to be erythema multiforme, or Stevens-Johnson syndrome. What is the primary indication for isoproterenol? That's going to be termination of torsades, basically because you increase the heart rate, which decreases the QT interval and reduces your risk of torsades. What would you expect to see on a BAL cell count if an infection is present? That would be a polymorphonuclear predominance or neutrophilic predominance. Now, if you see a BAL and it's very bland, so there's just like macrophages and histiocytes, then that argues against infection. But if you see those neutrophils all in there, then that's more suspicious. Do lacunar strokes typically present with hemispheric symptoms such as visual field cuts, aphasia, or neglect? The answer is no. Usually only presents with motor or sensory findings, which can kind of differentiate a little bit from some of the cortical strokes that you might see. When should platelet pheresis be considered for patients with essential thrombocythemia? That would be platelets greater than 1 million. It's not a strict cutoff, but just like extremely high levels of platelets and the addition of an acute bleeding or thrombotic event. And then once you get them to less than 400,000, you should start cytoreductive therapy. How can respiratory alkalosis cause hypocalcemia? So respiratory alkalosis is going to cause hydrogen ions to unbind from albumin, and then calcium is then going to bind to the albumin, and that way the calcium in your bloodstream is actually going to go down. All right, and now we're going to get to our 45 old questions. Those are the 30 reviews that we had to do. 3 functions of thyroid peroxidase. I actually honestly don't remember this card that well, but it basically converts iodine into the active form of T3 and T4. So organic oxidation of iodine, thyroglobulin, tyrosine residues. Women with primary ovarian insufficiency and no obvious cause should be tested for what gene mutation? I think it's, I actually don't remember this one. So that's the FMR1 gene, which is for carriers of Fragile X. And this causes accelerated follicle depletion. So I'm going to mark again for that one. Lung volume reduction surgery in COPD can be considered in patients with emphysema in what location? This is typically going to be in the upper lobes. I'm not sure why it's predominantly in the upper lobes, but this is where you like chop off a piece of the lung in order to reduce the burden of their COPD. Like you cut out a bunch of the diseased lung essentially. What is the mnemonic for lung development stages? It's basically, I don't really remember. Every pulmonologist can see alveoli. This is something from step 1. A lot of these questions that aren't that useful to me anymore, even if I don't get it right, I just mark it as good again because I don't really feel the need to see some of these cards anymore. Like I don't really need to know that the lung develops in embryonic, pseudoglandular, canalicular, whatever stages. But I do like to keep it in my Anki deck because if I ever need to search for it, I remember that I still have this card. So we'll mark good for that one. What is a newer mode of mechanical ventilation that reduces vent dysynchrony? By placing a pressure sensor in the esophagus. This is called naval, something with an N. NAVA, I think. Yeah, NAVA, neurally adjusted ventilatory assist. Triad consisting of meningitis, endocarditis, and pneumonia. This is Osler's triad. What is the treatment for physiologic jaundice of the newborn? That's going to be phototherapy. How many milliequivalents of sodium is in lactated ringers? That's 130 milliequivalents. Control of postpartum hemorrhage besides oxytocin would be methergine, which is contraindicated in patients with hypertension. Most common cause of maternal death due to eclampsia is seizures or intracerebral hemorrhage. So I'll mark again for that. There's more OB questions that aren't as relevant to me anymore, but sometimes I still like to know some of these. Syndrome characterized by polyneuropathy, organomegaly, endocrinopathy, monoclonal gammopathy, and skin changes. This is basically a mnemonic in itself. So POEMS is the POEMS syndrome. Rare and paraneoplastic syndrome due to underlying plasma cell dyscrasia. How do you choose the antifungal for neutropenic fever prophylaxis in chemo patients? Basically, the ID doctors are going to look to see what antifungals are compatible with their chemotherapy regimens. So it's based on the compatibility with chemo regimens. Which skin cancers have greater increased risk from total sun exposure versus brief, intense sun exposure? I always get this one wrong, but I believe brief, intense exposure is going to be your squamous cell, and total sun exposure is going to be more of your melanoma. So let's see. Oh, I actually had that completely backwards. So I'll probably mark this again. You can see how my ease is really bad on this one because I always get this one wrong. But total exposure is going to be squamous cell, and intense exposure is going to be basal cell and melanoma. What vitamin should you assess it for in all patients admitted for COPD exacerbation? That's going to be vitamin D. Studies have shown that supplementation in patients with severe deficiency results in 50% reduction in episodes and hospital admission. What is the most sensitive lab value for diagnosing hypothyroidism? That would going to be TSH. What medications cause hyperkalemia? Your ACE inhibitors, aldosterone antagonists, things like that. Yeah, pretty much. What's the most common pituitary tumor in men 1? That's going to be I actually don't remember. Most common pituitary tumor is going to be a growth hormone secreting. It's a prolactinoma. What complication of intestinal malrotation requires immediate surgical intervention? That's going to be volvulus. Okay. How can you tell the difference between drug-induced lupus and SLE? That's going to be antihistone antibody, or the fact that drug-induced has no involvement of skin, kidneys, or central nervous system. What is the underlying cause of hyperthyroidism in toxic adenoma? Basically, over-release of preformed thyroid hormone. What type of hypersensitivity reaction is myasthenia gravis? Probably type 2. It's a direct antibody mediated. Why should a patient increase their intake of vitamin D when starting carbamazepine? This is because of CYP inhibition of vitamin D, like hydroxylase. Basically they need to increase their intake because they're going to be going through their vitamin D more quickly. Tetracycline treats chlamydial bronchitis and atypical pneumonia. It's going to be doxycycline, always doxycycline. How should you change warfarin dosing after starting a patient on amiodarone? That's going to be amiodarone, again, is a CYP inducer, so it's going to reduce the level of medications in your blood, so you're going to have to increase the warfarin. Oh, amiodarone inhibits cytochrome. Oh, right. So how come my previous one said that it was an inducer? Oh, that's carbamazepine. Sorry. Yeah, I got that one wrong. How should you calculate weight-based insulin dose for a normal weight patient? That's 0.4 milligrams per kilogram. Units per kilogram, I mean. But then it depends on if they're frail or overweight. Then you do a higher dosing. What team can you consider consulting to help develop behavioral plans with misbehaving patients? This is something that's available at UC Davis. It's the best team. Poliovirus is acid stable, which allows it to spread fecal orally. Age 4 is going to be imaginative play or cooperative play. Yeah, so cooperative play. Lab test to assess short-term risk of premature labor is the fetal fibronectin. Protein believed to keep the amniotic sac glued to the lining of the uterus, and presence in vaginal fluids predicts premature labor. Fulfirinox is a chemo regimen for what cancer? Usually pancreatic cancer. In general, use Fulfox or Fulfiri for GI malignancies, Fulfirinox for pancreatic cancer, and Fulfoxiri for metastatic colorectal cancer. Bupropion contraindications are going to be bulimia, low weight, seizures. Complications of MI from RCA occlusion is going to be bradycardia. Really going to be heart failure. Yeah, biggest one's going to be bradycardia. Tetracycline, doxycycline, headache, fever, asymmetric paralysis with fasciculations. This is going to be West Nile virus. Poliomyelitis. Okay. Stroke affecting nucleus ambiguous, vestibular nuclei, spinothalamic tract, spinal trigeminal nucleus. That is going to be, I don't really know these ones very well. These localization of stroke syndromes. It's probably like medial medullary or something, lateral medullary syndrome. So I'll mark it as, I think I'll mark it as right because I honestly don't know how this would be applicable to me at this point. Maybe I'll mark it as hard. Are endothelin inhibitors, PDE5 inhibitors, and or prostanoids indicated for pulmonary hypertension secondary to LV dysfunction? That would be no. It's only for like type 1 pulmonary hypertension, like idiopathic pulmonary hypertension. Normal portal pressure gradient is less than 1 to 5. Okay. How do inhaled anesthetics affect the airway diameter? They cause bronchodilation. Monozygotic twin cleavage at 8 to 12 days are going to have a separate chorion or a shared amnion. Shared amnion and shared chorion scab. What kind of albumin should be given to a patient undergoing large volume parasites? That's going to be 25% albumin. You don't want to give them 5% albumin because you want to give them as concentrated of a solution as possible so you're not volume overloading them. Contraindication for using sildenafil and tadalafil in erectile dysfunction is going to be right-sided heart failure, I believe, because you're going to be reducing their preload. It's going to be nitrate use. Probably again because you're just like dropping their preload too much. Flushing, throbbing headache, palpitations, abdominal cramps after eating improperly stored seafood. Whenever it's a seafood infection, think Vibrio vulnificus. Oh, I guess I'm wrong on that one. Scromboid poisoning. This is like pretty rare. Like came up on a test exam question once or something. How should you change warfarin dosing after starting a patient on amiodarone? We did this one earlier, but we should reduce it because amiodarone inhibits CYP 450. Isoniazid may cause hepatotoxicity and peripheral nerve damage, peripheral neuropathy, as well as these other problems. Hypoalbuminemia from nephrotic syndrome may result in what physical symptom? It's going to be edema all throughout. Test check if metabolic alkalosis is saline responsive or saline resistance. That's going to be a urine chloride. So urine chloride less than 20 and urine chloride greater than 20. That is kind of the cutoff. Women with primary insufficiency and no obvious cause should be tested for the FMR1 mutation. Which skin cancers have increased risk? Total sun exposure is going to be squamous cell, and brief intense exposure is going to be melanoma and basal cell. Most common cause of maternal death due to preeclampsia is going to be intracerebral hemorrhage. And what's the most common pituitary tumor in men 1 is going to be prolactinoma. And that is it for now. So we have gotten through all of our Anki cards for the day. Now let's move back onto our custom quiz. So we're going to start by reviewing the previous questions that we did last time because we got a couple of comments from you guys last time. So thanks, first of all, for commenting on my previous video. So Pictures96734 said, thanks for doing this. These live streams are a great way to study passively at the end of the day/night. The unedited version is definitely the way to go so we can get to hear out your thought process and compare it to our own. Any chance you will be re-explaining the first few questions that were cut off. So I'm going to take this opportunity to respond to some of or basically review some of those questions we did earlier. Irrelevant also commented here, was unable to catch the live session, but appreciate the unedited upload. I like hearing your thought processes and I can kind of study along with you. I could only really answer the pharmacy/drug related questions, but I'm learning a lot hearing from a physician's perspective. Thank you guys for commenting on my first stream that I posted last time. And let's get into the Mixapp questions, starting with question number 1. This is a 71-year-old woman who was evaluated in the emergency department 1 hour after acute onset of severe headache and left-sided weakness. They basically gave a history that she had a stroke, and then she had elevated blood pressure. And basically the question was trying to figure out in somebody with an acute hemorrhagic stroke from high blood pressure, what medication should we be giving them to treat their hypertensive emergency? Because hypertensive emergency, again, is blood pressure greater than 180 over 110 with symptoms. And in this case, the symptom is a stroke. And so in this case, we would go with intravenous nicardipine. Intravenous nitroprusside is an option, but nicardipine has some advantages in patients who had a stroke because it has this kind of anti-cerebral vasospasm effect. And so that's one of the benefits of using nicardipine here. Initially, when I was doing this question, I got a little confused on whether we should be lowering this patient's blood pressure, because if a patient has an ischemic stroke, you actually want to keep their blood pressure high. So in ischemic stroke, if they had an intervention, then you want to get their blood pressure to a goal systolic less than 185 over 105. If they did not have an intervention, you actually want to let their blood pressure be as high as 220 over 110. So that's why I was a little bit confused, but then I noted that it was a hemorrhagic stroke, in which case we do want to lower their blood pressure much more rapidly. And in this case, the goal is to lower it to at least less than 140 systolic or less than 160, depends on where you look at, to help prevent the hemorrhage. So question number 2, a 25-year-old woman is evaluated for a routine wellness visit. Which of the following vaccinations should be offered to this patient? This patient was a completely healthy 25-year-old woman who had Tdap that was given within the last 10 years, so she doesn't need a Tdap vaccine. She had her adequate meningococcal vaccines at age 11 and 16, as well as a flu vaccine. Now, the only 2 choices after that are HPV vaccine, which are indicated to all women up until age 26, and then a pneumonia vaccine, which would only be indicated in patients who have some other kind of underlying disorder, like diabetes or HIV or some other kind of problem, or like COPD or asthma or something. Then they might be candidates for getting the pneumonia vaccine. But otherwise, if they're completely healthy, they should wait until they're 65 to get that. Question number 3, a 45-year-old woman is evaluated for heavy menstrual bleeding. And subsequent evaluation for secondary causes of abnormal uterine bleeding, including endometrial cancer, was negative. In addition to oral supplements, which of the following is the most appropriate management? And the answers were combination oral contraceptive pill, endometrial ablation, leave an IUD containing a prostaglandin, and then a oral progesterone. And the answer was an IUD. And what I said on this question when I was doing this is that OBGYNs love IUDs because IUDs have so many benefits, and they basically avoid a lot of the side effects of a lot of the other medications. So this person has heavy menstrual bleeding. She has a history of a DVT. So oral contraceptive could be a treatment for heavy menstrual bleeding, but in the context of a 10-pack year smoking history and a DVT, this would not be something you would prescribe to this person. Endometrial ablation is actually an option here, but because this patient does not want to become pregnant in the future. However, usually you want to start with medication and more conservative management first, for example, an IUD, to see if that will obtain this control of their heavy periods, rather than going straight to a more invasive procedure like endometrial ablation. And then progesterone, I forget, mainly... maybe used to promote withdrawal bleeding for women who wish to become pregnant. Yeah, so basically it's just not a good medication in this case. Question number 4 is a 37-year-old man evaluated in the ED for right-sided weakness, medical history significant for heart failure with placement of an LVAD 2 years ago. CT head shows sulcal effacement and loss of gray-white differentiation in the territory of the left middle cerebral artery. Which of the following is the most likely cause of this patient's stroke? So the answers are carotid artery stenosis, cryptogenic stroke, lacunar infarction, and LVAD thrombosis. So carotid artery stenosis could be an option, but this patient would have to be a lot older. So you would not expect significant intracranial or intracranial atherosclerosis only at age 37. Cryptogenic stroke, most common cause is going to be AFib or undetected AFib, but he has a more convincing cause for why he could have had a stroke. So that's why that was not the correct answer. Lacunar infarction is a deep brain stroke. The left middle cerebral artery is not a deep brain structure. It's a cortical stroke area. So lacunar infarction is also not correct. And then mainly his medical history of having this LVAD, for which he's on warfarin, is most likely the reason that he had this stroke. The main reason is because warfarin is highly variable, and its INR has a very tight range that it has to be in, and it's very easily affected by, like, even your diet or whatever can affect your INR and your warfarin, your efficacy of your warfarin. And so in this case, most likely something happened. His warfarin maybe missed a few doses, maybe he changed his diet, and all of a sudden his INR was not within goal, and then he had a stroke. So that was the key to this question right here. And then the last question that we did yesterday, before my stream officially started having audio, is a 45-year-old man who was evaluated in the ICU for continued daily fevers. He was hospitalized 6 days ago for left-sided pleuritic chest pain, fever, cough, and yellow sputum. If you take a look here, you can see this like kind of effusion. It's kind of got this meniscus sign right here. And which of the following is the most appropriate management at this time? Look at this, 94% of people got this correct. But add steroids, add Zosyn, perform a thoracentesis, measure procalcitonin, or switch to daptomycin. So this patient was admitted 6 days ago, and he has IV drug use. It ended up growing MRSA, and he was started on vancomycin monotherapy on hospital day 3. But despite starting on adequate treatment thereafter, he continued to have fevers. And so now it's asking you what the next step in management should be. So going down here, steroids, we're not going to add steroids to this patient. There is some rising evidence that steroids in severe community-acquired pneumonia is favorable, but at this time, it's not really a standard practice. Adding Zosyn, so some of the things that you would get from Zosyn is that you would broaden to adding pseudomonal coverage and gram-negative coverage, as well as anaerobic organism coverage. Now, one of the things that you could think is that, maybe this is an empyema here or loculated diffusion, in which case adding anaerobic coverage could be considered. However, in this case, we already know that it's MRSA, which is not an anaerobic organism, and most likely, we don't want to add gram-negative coverage and pseudomonal coverage for no reason, because we already know he doesn't have Pseudomonas. So that's why that's not a correct answer. Procalcitonin is something that's released by bacterial infection and kind of gives us an idea of how much infection is going on in the body. Generally, we use it to figure out when we can de-escalate antibiotics. In this case, checking procalcitonin is not going to change the management. We already know he has a MRSA infection, so it's not like we're trying to figure out what kind of infection he has right now. And then daptomycin is not going to be an answer because this is a lung infection. And one of the things to remember for daptomycin is that it is inactivated by pulmonary surfactant. So it would not be appropriate to use daptomycin for the treatment of MRSA pneumonia in this case. Most of the time when you have a fever and an infection that is not resolving, it's a problem of not obtaining source control. And so in this case, he has a persistent loculated pleural effusion here. And if you kind of read through the rest of this here, really it's just suggesting that this needs to be drained in order to get adequate source control, which will then help you, fix these persistent fevers. Otherwise, you would continue vancomycin. All right, so let's move on to question 14, which was where we left off last time. And let's finish off this 20 question series and see how well we can get so far. Let's see how far we can, how well we can do on the last few questions. So far, we've only gotten one question wrong. So this is question 14. A 40-year-old woman is evaluated for a 12-year history of inflammatory arthritis, puffy fingers, Raynaud phenomenon, psoriasis, and gastric reflux disease. I'm starting to notice that Mixup really, really likes having a lot of rheumatology questions on here. So lab studies show positive anti-U1 ribonucleoprotein antibodies, which is a marker for mixed connective tissue disease. Which of the following complications of this patient's disease is a major cause of early mortality? Is that central nervous system vasculitis, pericarditis, pulmonary arterial hypertension, and rapidly progressive glomerulonephritis? On physical exam, vital signs are normal. Cyanosis of the fingertips is noted. Cardiac exam is normal. Lungs are clear. No friction rub. Heard on exam. Mixed connective tissue disease, it's mixed, right? It can cause probably all of these. But I think the one, I'm not 100% sure on this one, but I think the one that's standing out the most to me is pulmonary hypertension. I think these ones are all possible. But I think the one that really just is sticking out to me is pulmonary hypertension. So we'll go with that one. And yes, that is it. So I'll identify pulmonary arterial hypertension as a leading cause of mortality in mixed connective tissue disease. MCTD is rare. Age of onset is 30 to 50 years with a 9-to-1 female predominance. And overlap syndrome that includes lupus, polymyositis, and about 1/3 developed myositis, decreased esophageal motility, and fibrosing alveolitis. PAH occurs in 20%, with fatigue often the initial symptom. This is associated with a poor prognosis and is a major cause of mortality. CNS disease is common in MCTD, with trigeminal neuralgia occurring in up to 25% of patients, but vasculitis is rare. Pericarditis is the most common cardiac manifestation of MCTD, but it does not result in premature death. And the kidney disease is seen, but usually it's a membranous nephropathy. So, like I said, mixed connective tissue disease, a lot of these rheumatologic diseases, they can cause anything, just like on House MD, how they talk about how lupus can cause anything, and like every patient has lupus. Really it can do whatever it wants, but the strongest association here is going to be with the pulmonary hypertension. Moving on to the next question. A 58-year-old man is assessed for discharge from the hospital. He was admitted 3 days ago for fever and chills. He is completing intravenous daptomycin therapy. His CBC and CMP are normal. Which of the following is the most appropriate weekly monitoring of his daptomycin therapy? So don't need to read any of the rest of this. It's going to be a weekly creatinine kinase, and creatinine is what we're going to be checking for this patient. This is just based on, honestly, seeing patients on daptomycin so often that I've seen, we always need to be checking the creatinine kinase, the CK, every time, because it can cause that like myopathy. Let's see. Daptomycin should be discontinued in asymptomatic patients if CK levels increase to greater than 10 times the upper limit of normal, or CK is greater than 5 with symptoms of myopathy. Treatment with statins may increase the chance of developing an elevated CK level. It is suggested that statins be discontinued if possible during daptomycin treatment. All right, let's move on to the next question. A 49-year-old man is evaluated for a 6-month history of difficulty walking and frequent falls. An MRI of the brain is unremarkable. Which of the following most accurately describes this patient's abnormal movements? Ataxia, chorea, dystonia, myoclonus, orthostatic tremor. Ataxia is going to be like really wobbly. Chorea is going to be like a dancing movement. Dystonia is more like, the neck is stuck to the side. Myoclonus is going to be a jerking movement. And orthostatic tremor is, I've never heard of an orthostatic tremor, but basically, what do you think? A tremor, but probably when he's standing up or something. So, he had a prolonged hospitalization for pneumonia, cardiac arrest. So you really don't need all this information here. You really just need, basically, when you first read, when you skip reading the body of the question and you just go straight to the final question and the answers, it really helps prone you to what you need to be on the lookout for. Because now I don't have to waste all that time, trying to process this information up here, because I know it's ultimately not very helpful. Really, what I just need to look at is what this patient's physical exam is like, right? So muscle strength is normal in all limbs. At rest, few rapid jerky movements are noted in various limbs. Remember I said myoclonus is that like jerky movement. On standing, rapid non-rhythmic shock-like movements are noted in the trunk and various lower extremities. There are brief lapses of muscle tone in the legs, which lead to loss of balance. These movements are not suppressible. Plantar response is flexor bilaterally, and clonus is absent. So yeah, this is myoclonus because it's jerky movements. Remember, wobbly, unstable, not coordinated, ataxia. Chorea is going to be dancing. Dystonia is going to be like stuck to one side or something. Myoclonus is going to be jerking movements. Okay. Post-hypoxic myoclonus, Lance-Adams syndrome, occurs in patients with a history of hypoxic brain injury suggested in this patient by his previous cardiac arrest, and is characterized by prominent action-induced myoclonus that impairs ambulation because of a combination of positive and negative myoclonus. So now I learned something about negative myoclonus, where kind of that lapse in tone is also consistent with myoclonus. Ataxia is wide-based gait, incoordination, and dysmetria. What's dysmetria again? Inability to control distance, speed of movements. Chorea is dance-like movements. Dystonia is sustained muscle contractions. Orthostatic tremor is a high-frequency rhythmic tremor that emerges in the legs only during standing. So basically what I described for all of them. So question 17, I might need to get a drink of water soon. There's a lot of talking. But a 22-year-old man is evaluated for acute onset of fever, chills, and let me know if, let me see. Let me make sure I have the chat open just in case anybody's been chatting in here. Oh, you guys were chatting in here. I totally put the wrong one in here. Frick. I should have been, I could have been interacting with you guys the whole time. Sorry, let me update this. I put the wrong chat in the box there. You're like, why am I whispering? Are your Anki cards online somewhere? My Anki cards are not online. Because for me, I feel that Anki cards, people really get the biggest benefit, I think, when they are creating their own Anki cards, because then you know what you're trying to test yourself on and what you're trying to remember. The other thing is my Anki deck has cards that are like 4 or 5 years old at this point. And so a lot of the cards, if I post it online for somebody, like a ton of those cards are going to be extremely irrelevant to people. Like even now, I have a lot of cards that are not very relevant for me. And I just keep them in there just because I like having like a repository of all the cards I've ever made. And I can always search for it whenever I need to. But a lot of those cards are not really... they're not really, I don't think they'd be very helpful for a lot of people. That's probably the main reason. Why am I whispering? I'm whispering just because it's like the afternoon nap time for people in my house. So I just want to not be too disturbed too much. But also I feel like the ASMR potentially could be nice for you guys if you guys are watching this at nighttime and you're doing a little bit of studying, having a little ASMR mix app board review questions. That'd be kind of nice. A nice way to wind down for the night, right? So I don't know. You let me know. You let me know if it sounds weird if I'm whispering the whole time. I think one of the biggest parts that's difficult about making videos is like doing things where you are recording or speaking to a camera and knowing that there's other people in the house that are like listening to you. It just makes it feel very, very awkward. And so that's always been something I've struggled with. And I feel like I could have made a lot more videos if I had gotten over that feeling. And so that's another reason for why I'm whispering, is because I think because then it makes it a little bit less intimidating to me to be like shouting into the computer while like the house is completely silent and there's like other people in the house and just me feeling awkward. So that's kind of the reasoning there. So let's move on to question 17. A 22-year-old man is evaluated for acute onset of fever, chills, dyspnea, and non-productive cough. Chest radiograph demonstrates diffuse upper lobe micronodular opacities. Which of the following is the most appropriate treatment? Counsel the patient not to return to work, inhaled glucocorticoids, pirfenidone, and sirolimus. And do you feel like the quality of self-made cards gets better with time? I'm new to making them, but used pre-mades in the past. I feel like mine are always bad when compared. Yeah, I feel like the quality of your self-made cards definitely improves. When you make self-made cards, the thing that I always tell people is you need to make it so there is just one answer, and it's very defined. It's like a very defined answer, and so you either get it or you don't get it. The problem that people have with making their own Anki cards, I think, is they make the questions too broad, and then it's hard for them to tell when they're doing the card later, like, did I actually get that question right or not? So if you have a very complicated topic, for example, you should just make several cards, all testing one specific aspect of that topic. I did have this really good website that I would direct people to on guides to making good Anki cards. I'm not sure if it's still up because this was like 4 or 5 years ago. Yeah, I think it's... Yeah. This is here. So let me link this to you. But this super memo link is one of the ways that I really force myself to try and make high quality cards that I felt were effective for me, and how I think you can also learn to make really good cards as well, just by following the principles in that article right there. All right, back to the question. So this person, again, has that chills, upper lobe micronodular opacities, pirfenidone. I can't totally remember what the action is for that. Sirolimus is going to be immunosuppressant. Glucocorticoids, also immunosuppressant. And then this one, counsel the patient not to return to work. This is kind of giving me the sense of hypersensitivity pneumonitis, because hypersensitivity pneumonitis, the question stems are always, the patient goes to work, they get worse when they come back, they go to work and then they get worse. And the fact that we're having upper lobe micronodular opacities, that's another feature of hypersensitivity pneumonitis, is typically it affects the upper lung lobes more because, you're breathing in and all those allergens and irritants are going up to the top of your lungs. So we'll see. So he is a college student and spends summers using a combine to harvest wheat. So look, it's already looking like hypersensitivity, right? He does not wear respiratory protective equipment. His symptoms start at the beginning of a work week, progress to the point where he must miss several days of work, and then the cycle begins again. This is literally hypersensitivity pneumonitis in a nutshell. So again, think about symptoms worsening whenever they go to work, upper lobe predominance, and then, this answer right here of counseling the patient not to return to work. This is all like hypersensitivity pneumonitis. And no, the answer is not steroids. The answer would be steroids. Let's move this here. The answer would be steroids, I believe, if there's absolutely no way that the patient can avoid that contact. But even then, you have to get them the source of their inflammation is from contact with whatever that allergen is. So, you have to get them to avoid exposure to that. Although treatment of acute hypersensitivity pneumonitis with systemic steroids is appropriate for those with more severe disease, patient response is variable and prolonged use is associated with significant side effects. There are no data to support the use of inhaled glucocorticoids, and the primary treatment is to remove the offending agent. IPF is the most common idiopathic interstitial pneumonia. It occurs predominantly in older individuals. Diagnosis is rare in those younger than 50 years of age. Pirfenidone is a novel therapeutic agent that works on TGF-beta and TNF-alpha through an unknown mechanism. And this is an important step forward in the management of IPF, but they are not curative. Lymphangiomyomatosis predominantly occurs in women or with patients with tuberous sclerosis, cystic lung disease due to infiltration of smooth muscle cells, due to a rapamycin mTOR pathway, diffuse thin-walled cysts, and spontaneous pneumothorax. Treatment is with inhibition of mTOR with sirolimus. All right, 3 more questions, you guys. We're still keeping it up. At this point, even if we get the last 3 questions wrong, we'll still have an 80% correct rate, which is pretty good. So a 19-year-old man is evaluated for a heart murmur noted on physical exam. He has no symptoms. Echocardiogram demonstrates a dysplastic pulmonary valve with a peak instantaneous systolic gradient of 65 millimeters of mercury. Pulmonary regurgitation is moderate. The right ventricular size and function are normal, but RVH is present. The left heart size and function are normal. I'm not very familiar with this. So yeah, it looks like it's a lot of these weird genetic disorders, which I am not super familiar with. So which of the following is the most likely genetic disorder responsible for the patient's findings? So Down syndrome, is Down syndrome associated with dysplastic pulmonary valve with pulmonary regurgitation and right ventricular hypertrophy? I don't think so. Marfan and Turner's, they can cause a lot of issues. So Turner's is associated with bicuspid aortic valve. Marfan is associated with like aortic root dilation. Down syndrome is associated with these ventricular septal defects and all that stuff. Noonan syndrome, I am not very familiar with, but I've seen it. I've seen this word before. But I think this is probably it because this is a combination of things that I don't really know that well. And then I kind of know the buzzwords for the other ones like Down syndrome, Marfan, Turner, that make me less inclined to pick them. So I'm going to pick Noonan syndrome, and looks like that's correct. So Noonan syndrome is an autosomal dominant disorder commonly associated with congenital cardiac lesions, including pulmonary stenosis with a dysplastic valve. It should be considered in all patients with pulmonary stenosis, particularly those with short stature, variable intellectual impairment, unique facial features, neck webbing, hypertelorism, and cardiac abnormalities. What's hypertelorism again? It's like jaw? Oh, increased distance between 2 body parts. Patient has severe pulmonary stenosis with a palpable late peaking systolic murmur, absence of ejection click, and features of right ventricular pressure overload. So yeah, if you look here, Down syndrome is associated with septal defects, ventricular septal defects, and tetralogy of Fallot. Marfan syndrome is associated with aortic dissection. Right? And Turner syndrome is affected by bicuspid aortic valve, aortic coarctation, and aortic aneurysm. All right. Oh yeah, and although pulmonary stenosis can occur in Turner syndrome, this man could not have Turner syndrome because Turner syndrome is XO, right? So they're all phenotypically female. There's no Y chromosome. So the fact that this is a male patient makes Turner syndrome also not a possibility. Question 19, a 53-year-old woman is evaluated for intermittent sensory loss in the hands and an occasional shock-like sensation from the neck down the back with neck flexion. This sounds like multiple sclerosis. So that's the Lermet sign, which is the shock-like sensation from the neck down. Which of the following is the most appropriate diagnostic test to perform next? Electrodiagnostic studies of the upper extremities, flexion, extension radiography of the cervical spine, B12 level, and TSH. So maybe it's not multiple sclerosis, because that is actually diagnosed with like MRI, I believe, and maybe like lumbar puncture showing in with oligo CSF bands or something. So let's see. She has a 15-year history of rheumatoid arthritis. All right, initially, I'm already thinking flexion extension radiography of the cervical spine, because they get this kind of subluxation of C1 and C2. Medications are methotrexate, etanercept, and folic acid. She's got ulnar deviation. She's got a bunch of findings that are suggestive of rheumatoid arthritis, basically. Yeah, and so this one is definitely subluxation of C1 and C2 from her severe rheumatoid arthritis. All right. So, yeah, it's not just multiple sclerosis that can cause that Lermet sign, but you also got to keep in mind some of these other things. As soon as I read that line, and yeah, DFAN mentioned this as well, but as soon as you see that history of rheumatoid arthritis, like it's going to be that they're going to test on that like neck flexion problem. Consideration of surgery is necessary for patients with significant subluxation, especially if symptomatic. Undergoing general anesthesia, should have cervical spine radiography with flexion extension to assess for subluxation, which can lead to neurologic compromise. B12 deficiency has paresthesia and ataxia in the lower extremities. Hypothyroidism could cause a distal peripheral neuropathy, and electromyography would be testing for other kinds of neuropathies. All right, last question, you guys. A 45-year-old man is seen for follow-up evaluation for depression and to review the results of laboratory testing. TSH level is 7 and free T4 level is 1. So it looks like a slightly elevated TSH and a slightly low T4 level. Which of the following is the most appropriate management? Measure TPO antibodies, measure thyrotropin receptor antibodies, measure T3 level, prescribe levothyroxine, or repeat TSH testing in 2 months. So this question, if you're looking for TPO antibodies, you're looking for autoimmune thyroiditis or like Hashimoto's thyroiditis. If you're measuring thyrotropin receptor antibodies, a lot of times you check that when you're looking for like Graves' disease, from what I know. Measuring the serum T3 level is not something we typically need to do unless you're having a very complicated like endocrine patient in ICU. We've checked it a few times, but I don't think we really need to check that here unless you're like really unsure of what's going on. Prescribing levothyroxine is a possible option, and then repeating TSH testing is 2 months. In 2 months, we'll have to see. We'll have to see if these symptoms we think are attributable to his thyroid disease, because right now at this point he has very mild subclinical hypothyroidism. But just because it's subclinical, and by subclinical I mean his T4 level is normal, but just because it's subclinical doesn't mean they can't be symptomatic from it. They can still have symptoms from it, which could be causing these symptoms. So he was seen 1 month ago for a 6-month history of depressed mood, difficulty sleeping, decreased appetite, weight loss, and fatigue. Weight loss is a little bit counter to what we would expect for hypothyroidism. Major depressive disorder was diagnosed and escitalopram was prescribed. Today, the patient reports a significant improvement in his mood, appetite, and quality of his sleep since starting treatment. Okay, so he got an antidepressant and he's feeling much better. So now it's making this much less likely that this is hypothyroidism that's contributing, right? So in this case, I think we would go mainly for the more conservative approach of just repeating the testing in a couple months and see what it looks like. So that's what I'm going to go with. All right, and we completed this quiz with 95% correct, you guys. That's definitely like my best score yet. I think maybe doing this with you guys helps me think through it a little bit more, because otherwise I'm like rushing a little bit more. I'm not thinking through all the options as much. So a couple notes for subclinical hypothyroidism. There are times when you do want to treat subclinical hypothyroidism. So, should subclinical hypothyroidism be treated if patients are having convincing hypothyroid symptoms? The answer is yes. So first of all, if their TSH is greater than 10 and their T4 is normal, you still want to treat for subclinical hypothyroidism just because of how severely elevated the TSH is. If the TSH is 7 to 9.9, treat if age less than 70, or if there's convincing symptoms in age greater than 70. So he's actually kind of at this cutoff because his TSH was 7, right? So if it was 7.1, according to this, which I believe is up to date, and probably some other resource that I found as well, UWorld down here, if he was 7.1, he would have actually met criteria for treating his subclinical hypothyroidism. If TSH is 5 to 6.9, treat if age less than 70 and convincing symptoms. Do not treat in age greater than 70. So he was very close to, meeting the requirements for treating. And this is from UWorld here. This is from Up to Date here, and this is from UWorld down here. Yeah, Defan. Thank you. Yeah, I don't think I normally get 95%. That was pretty high. All right, let's take a quick break. I'm going to do probably 10 more questions, and we'll see how we do. I'm going to get some water just because talking is, it's like a lot of talking. But you guys are really helping me out with these questions. I hope you guys are enjoying watching, and I'll be back in just a couple minutes. 1 second. Yes, if he remains symptomatic, he should have gotten levothyroxine. I agree, Apurva. All right, bear back. All right, you guys, I am back. So let's go again. I think I only have the capacity to do another 10 questions on stream because it takes a lot more effort to do these on stream, obviously. I was thinking about whether I should duplicate this quiz and just do another 20 questions, but it takes a while to get through 20 questions when you're like talking through your thoughts on everything. It does make me a little after starting streaming, I kind of feel like if I do these questions without doing it on stream, I'm kind of missing out a little bit on doing some of these questions with you guys. So it makes me kind of feel bad doing some of these questions on my own. But I do think I only have a limited capacity where I can be discussing all these questions live the whole time. But at some point I am going to deplete all these questions because in total there are there are 1,200 questions on here. And we'll see. Depending on how much you guys like this, maybe in the future I should just buy board review question banks and just do questions, from now and then, every now and then. So we'll make a new quiz. Let's just make 10 questions. We'll choose all specialties. And you can see there's 1,200 mix-up questions. I still have 1,010, so my goal is to try and do 80 to 100 a day because I'm taking boards in about a month. And then we'll do a 10-question quiz. And we'll say second live stream. I hope you guys are having a good day so far. I really miss streaming. I used to stream a lot when I was playing StarCraft professionally. And, having a stream open and interacting with the chat and just kind of doing things with other people is like very fun and social. I really miss that aspect of streaming. So hopefully this will be a fun way for me to kind of get back into that, but also be like pretty productive at the same time. All right, so let's get started. Question number 1, a 22-year-old man returns for follow-up evaluation. He was recently diagnosed with HIV infection and he began antiretroviral therapy 2 weeks ago. I remember watching you way back then too, LOL, good times. Yeah, I'm actually very surprised at how many people who used to watch me for StarCraft are still, watching me for like medicine videos and stuff too. So it's pretty cool. It's definitely like a cool feeling. All right, so recently diagnosed with HIV, started antiretroviral therapy. CD4 count is 500, hepatitis A positive, IgG positive, IgM negative, surface antibody negative, and surface B antigen positive. Ooh, not good. He's got hepatitis B. This is going to be a vaccination question. So which of the following is the most appropriate immunization to give today? It's going to be the pneumococcal hepatitis A vaccine, which I would not give. He's already immune. Hepatitis B vaccine, I would not give. He's already infected. So remember, if the antigen is positive, that indicates that there's like an active infection going on. Or an HPV vaccine. In this case, he is almost certainly going to qualify for a pneumonia vaccine. Remember, in the beginning of this video, I already discussed if anybody is age 19 to 64 and they have some other chronic medical condition, they should be getting a pneumonia vaccine. So he received influenza vaccine and the 13 PCV vaccine at that time. He has sex with men. This, I feel like, it might sway you to picking the HPV vaccine. And I still feel like that could be an option. But usually I think it's really just up until age 26 is when people would get it. He is 22. So we'll see. I don't know. I think for me, the biggest thing I would worry about is pneumonia, right? You don't want somebody with HIV getting pneumonia. A few small lesions consistent with warts are noted on the penis. Yeah, I think I would go with a pneumonia vaccine here. Oh, and it was the HPV vaccine. So already starting off this one with the wrong answer, you guys. I knew this was going to happen at some point. I'm still surprised I got 95% on that last one. PCV20 is older now, that PCV20. Yeah, you're right. Actually, I really, really like that we have PCV20 now, because all the different, ways that you needed to like give PCV13 and then the PPSV23 in like a certain order was like so annoying to remember. You had to like look it up every single time. Now you can just give PCV20 like right away, right off the bat, and you're basically fine. So HPV. He's in an age group for which HPV is recommended. Pneumococcal vaccine is important for all patients with HIV infection. They should receive the 13-valent and 23-valent polysaccharide vaccines in that order. So this is MixApp 18. So I think this was based like 2 years ago, probably. So some of these things are not totally up to date, and that's probably why they don't have the PCV20. The patient has already received the pneumococcal conjugate vaccine and needs the polysaccharide vaccine, but at least 8 weeks must elapse between the two vaccines to allow for better immune response. All right, so that makes sense. Let's move on to the next question. A 72-year-old woman is evaluated during a routine visit. Hypertension treated with amlodipine and losartan, creatinine is normal, potassium is normal. According to the target blood pressure goals recommended by the ACP and the AAFP, which of the following would be an appropriate management? Add chlorthalidone, increase amlodipine, increase the losartan dose, and make no changes to antihypertensive medications. So this patient is 72 years old, so she's on the older side, but she's relatively healthy. She is physically active, playing tennis and golf. If this was a patient who's like falling all the time and has like stroke, ESRD, and like, COPD and all this stuff, that would be a patient you may consider doing a little bit more lenient blood pressure management for. But in this case, this is a relatively healthy, functional woman. The The AHA and ACC guidelines is that all patients should have a target blood pressure of less than 130/80. I don't know the specific recommendations from the ACP and the AAFP, but I would be pretty shocked if it was significantly different than what the American Heart Association recommends. And so in this case, she is above goal. Even if you're kind of being a little bit more lenient because of her age, she is still above goal, because basically we should get her less than 130. And if you really want to be conservative, you could be less than 140, but she's definitely above goal. So the question is, you can share your username and password for Mixapp19. Yeah, I don't know. I might have to take you up on that offer. We'll see. Maybe we can talk to you later about that. I have to check their terms of service and whatever, make sure it's not like super illegal. But thank you for offering that. So amlodipine and losartan. Do we want to add chlorthalidone? Do we want to increase amlodipine, increase losartan, or make no changes? This is a little hard for me because I feel like you could really do any of these. Pretend like you really could do any of these. I wouldn't add a third medication, I don't think. Although we did have that recent question where, adding an additional medication gets you better blood pressure control than increasing the dose of something else. But I really have no idea how you would choose between these two, because I think you could go with either of them. So that's kind of making me doubt myself and wonder, should I be considering A or D? But I think she's not at goal. At least if I saw this patient in my clinic, I would be trying to get her less than 130. Didn't you say earlier that upping dose has diminishing returns versus adding something new? Yeah, exactly. That's literally the card I had right here. This is a question we did last time. When titrating BP meds, is it more effective to add a new agent or increase the dose of existing medications for optimal BP control? Add a new agent. You get diminishing returns as you increase doses of therapy to their max doses with increased side effects. For optimal BP control, adding a new agent is actually better. General rule of thumb is that 75% of an agent's blood pressure lowering effect may be achieved with 50% of its maximal dose. So if I'm going off of this, the answer is probably add chlorthalidone. But then you get into this whole thing of, are we really going to add a thiazide diuretic, which in elderly females especially is going to cause hyponatremia and cause overdiuresis and dehydration and a lot of other and then hypokalemia, a lot of other electrolyte abnormalities. In this case, I would favor just going up on one of the medications she's already tolerating, reducing the need for polypharmacy. So I will tell you what I would do is increase the, I just don't know how to choose between these two, because I think you could increase either. But I'm just going to say increase the losartan. And I think it's going to be wrong though, because it doesn't make sense to me how you could choose between these two. So we'll see. Make no changes. See, this is I don't know. I don't think this is right, because ACP and AAFP, what's their guidelines? This person's 140 over, ACC, AHA guidelines for blood pressure is less than 130/80. So see, 2017 ACC, AHA guidelines recommend an SBP treatment target goal of less than 130. Also, a diastolic treatment of less than 80. And this is based off the combination of two landmark trials. There's the SPRINT trial, which showed that a goal of less than 120/80 was the best. And then there was the ACCORD BP trial, which said that we should only be aiming for less than 140/90. So then they took the average of those two trials and they basically came up with this goal of 130/80. I would go up on losartan or amlodipine in clinic too. Yeah, that's what I think. So let's see what they say. According to blood pressure goals by ACP and AAFP, this woman's blood pressure is at target and no changes are necessary. Man, they're trying to treat the blood pressure of 150. Oh, see, they even mentioned it here. On the other hand, the 2017 ACC AHA blood pressure guideline recommends a systolic blood pressure goal of less than 130 for non-institutionalized ambulatory community dwelling patients greater than 65. See, they even acknowledge that. Come on. Why are we using these two different guidelines where one says we should target less than 150 and then one says target less than 130? How do I report this question? Where's the report button? Isn't there a way? I want to complain about this question. Oh, I don't know. Yeah, see, this content was last updated in August 2018. So I think this is honestly just like an outdated question. Because back in 2018, that's when they were still using this JNC8 guideline, which was like released in like 2010 or 2014 or something. And yeah, so they were targeting. So I think this is just like out of date, this question. Yeah, I guess there's no way to actually report this question because this is like already part of their outdated set of questions. So anyways, I think we were right, you guys. We deserve the credit for that one. A 42-year-old man is evaluated in the ED for a 3-hour history of severe chest pain that radiates to the back. He's got what looks like some kind of dissection flap going on his CT scan. Which of the following is the most appropriate management? I mean, we got to repair this. The question is it open surgical repair or is it thoracic endovascular repair? I don't think you're going to do medical therapy alone. I think if it's just a descending aortic dissection, you can try medical therapy, but even then, you would be calling surgery like 100% just to, check this out. So the pain is sharp and tearing in character. Medical history significant for hypertension. Blood pressure 128 and 162 in the left arm. Pulse is 110. Lungs are clear to auscultation. Other than tachycardia, exam of the heart is normal. Okay, so open or thoracic? I would say this may be a more complicated kind of repair, and so I'm just going to go with open, but I honestly don't know whether it's open or thoracic. Maybe you guys do, but we'll go with open. The thing is, this says medical therapy alone, which is not correct. At least I don't think it is. But keep in mind that your medical therapy is still very important at this stage. So if somebody has aortic dissection, you should be getting their heart rate down to like 50 or 60, and you should also be getting their blood pressure as low as low as tolerable. So let's see. Yeah. Aortic dissection rapidly lower to target 100 to 120 in 20 minutes. And then where is heart rate? There's something that I had for heart rate, but you're supposed to get their heart rate like super low also. So a lot of times you use like labetalol or esmolol, something like that. So anyways, open surgical aortic repair. Type A aortic dissection. I always forget, but type A is anything that's involving the aortic, ascending aorta, and then type B is only descending. And then there's the Stanford type A, or 1, 2, 3. It's always very confusing. Yeah, so type 1 is ascending and descending, type 2, type 3, and then type A is just anything that is involving ascending. So I do like the Stanford system more. It's a little bit easier to remember. Isn't that decisions for the surgeons anyways? Yeah, I agree, Dallas. We're internal medicine here. Why are we making the decision of whether it should be an open surgical repair or this should be an endovascular repair? Yeah, so make sure you still do that, medical therapy with beta blockers and nitroprusside and stuff, or labetalol. All right, a 66-year-old woman is evaluated during a follow-up visit. Oh, where did that heart come from? I saw a heart on the chat. All right, a 66-year-old woman is evaluated during a follow-up visit for a 5-year history of chronic autoimmune pancreatitis. On physical exam, the patient is frail appearing, BMI is 21, abdomen is scaphoid, Bowel sounds are present. Mid-epigastric palpation reveals tenderness. Which of the following is the most appropriate next step in management? Add lorazepam. If this person's like getting to hospice, then maybe we could add some anxiety medication, but we'll see. Prescribe naloxone. So this is if somebody is like, if they're like overdosing too much on their pain meds. Recommend weekly nursing visits before each opioid prescription. Switch the fentanyl patch to short-acting hydromorphone. So she has constant severe aching mid-abdominal pain that radiates to the back. Her only surgical option is a pancreaticojejunostomy, a procedure that she is not ready to accept. She has previously tried several TCAs, venlafaxine, gabapentin, morphine, tramadol. A fentanyl patch was substituted for oral morphine recently, and over the past 6 weeks, she has noted reduced pain and improved function. She lives with her husband and oldest daughter at home. She does not smoke. She only uses fentanyl patch. Okay. Yeah, in this case, she seems to be doing well with this fentanyl patch. The safest thing that we should do is make sure she has a prescription for naloxone in case that she ever, gets, too sedated or something. The husband can run by and just give her something real quick. So pretty easy answer here. I don't see a lot of people end up picking this weekly nursing visits one, but I'm not sure why they would need weekly nursing visits for this case. So the most appropriate next step before continued prescription is to prescribe naloxone. Yeah. Yeah, weekly nursing visits are not currently recommended. So we can use the prescription monitoring databases to make sure they're not getting any other opioids, but no need for these weekly nursing visits. Next question. A 75-year-old man is evaluated for a 5-year history of hand joint pain and morning stiffness lasting a few minutes. Hand radiographs show joint space narrowing and osteophytes of multiple proximal and distal interphalangeal joints, and similar changes are seen in both first carpometacarpal joints. There are no erosions. Which of the following is the most appropriate next step in management? This sounds like osteoarthritis. He's got joint space narrowing osteophytes with no erosions. That sounds like osteoarthritis. And then, so we're not going to do all this other testing that they're asking for here, because joint space narrowing, if somebody has rheumatoid arthritis, you're basically going to see erosions. And you will also see symmetric joint space narrowing, whereas, osteoarthritis, it's like kind of more irregular. But let's see. He walks about a mile every day and plays tennis 3 days a week. However, the pain is limiting him from gripping a tennis racket. He has fatigue for the past 6 months. No other constitutional symptoms, shortness of breath, or rash. This might be a red herring, or what does red herring mean? It means like a trick, right? Oh, a clue or piece of information that is intended to be misleading or distracting. Yes, I used it correctly. I wasn't sure. History is also significant for hypertension and diet-controlled type 2 diabetes. Medications are losartan, acetaminophen, and aspirin. Vital signs are normal. Bony enlargement of multiple proximal and distal interphalangeal joints of the hand are noted. So that's the PIP here and DIP. So that is also more characteristic of osteoarthritis as well. Remember, DIP and PIP is going to be more osteoarthritis, and then MCP, metacarpophalangeal joint, and PIP, proximal interphalangeal joint, are going to be more rheumatoid arthritis. Psoriatic arthritis can be like all of them. Okay, but yeah, no further testing. I don't think we need to do anything for this guy. 93% of people got this right. Avoid serologic testing in patients with low test of pretest probability of connective tissue disease. All right, next question. A 52-year-old woman with a recent diagnosis of adenocarcinoma is seen for follow-up to discuss management plans. They have an 80-pack year history of smoking. Jeez. Peripheral blood smear is normal. Chest radiograph shows right upper lung mass and bilateral hilar and mediastinal lymphadenopathy. She will begin chemo for non-small cell lung cancer. Let's look at these labs real quick. Looks like the ferritin is high, iron is low, TIBC is probably low, and transferrin is slightly low. So this person's got anemia of chronic disease, and they're going to ask, oh, do you want to give iron for this? And it's going to be no. If they had iron deficiency anemia, which would be characterized by high TIBC and low ferritin, less than 30 or so, then it would be yes. But which of the following is the most appropriate treatment for this patient's anemia? Erythropoietin, any of these? No treatment indicated here because it's anemia of chronic disease. We got to treat the underlying condition. Inflammatory anemia occurs in response to the inflammatory cytokine. And so again, this is another example of, we just read the first question and then we just read, anything we thought would be pertinent. But I didn't even read this. I didn't even read this at all. It's like a waste of your mental energy sometimes to read some of this stuff up here. Now, usually on the real exam, I probably will look at it briefly to make sure that I'm not missing something important in there. But I actually didn't even look at this when we were reading this question just now. And you don't need any of that information. So inflammatory anemia occurs in response to IL-6, which causes proteolysis of the membrane protein ferroportin. Yeah, I actually don't know the mechanism of why anemia of chronic disease happens, but increased synthesis of hepcidin, and then lysis of ferroportin, and then absorption from gut is diminished. Yeah, okay. Well, then why is the ferritin level high if your absorption is diminished? Oh, as is iron release from macrophages. I see. All right. Question number 7. A 32-year-old man is evaluated in the hospital for symptoms of persistent asthma. Lab studies, CBC, CMP, IG are normal. Chest radiograph is clear and spirometry is normal. Which of the following is the most appropriate management? CT scan of sinuses, increased prednisone dosage, laryngoscopy, or polysomnography? I'm actually not sure what these are going for. Polysomnography, okay, we'll see if this looks like sleep apnea. Laryngoscopy, we'll see if we think this is some kind of upper airway problem, extrinsic airway problem or something. Increased prednisone, do we think his asthma therapy is not working? Probably not. It's probably working. And CT scan of the sinuses, do we think he has some kind of sinus infection? He was evaluated in the ED 2 days ago for dyspnea, accompanied by wheezing, dysphonia, and upper throat and chest tightness. Symptoms persisted despite use of albuterol inhaler and IV methylprednisolone, and he was hospitalized. He was diagnosed with asthma in high school and requires several doses of prednisone per year. He's currently taking albuterol, fluticasone salmeterone, Symbicort, I believe, and prednisone montelukast. Heart rate is high. Monophonic wheezing on inspiration. Yeah, so he's got some kind of... So remember, asthma and COPD, these reactive airway diseases, are going to have expiratory wheezing. The fact that he has monophonic wheezing on inspiration, that's more of like a stridor kind of picture. So he's got some kind of upper airway swelling going on. And you can see he's got this like throat tightness thing going on. So he's definitely going to need a laryngoscopy. I would want ENT to come take a look at what's going on over there. So vocal cord dysfunction. Vocal cord dysfunction is caused by paradoxical adduction of the vocal cords during inspiration, leading to functional upper airway obstruction. Diagnosis is suggested by dysphonia mid-chest or throat tightness with exposure to triggers. May experience mid-chest tightness. Vocal cord dysfunction is commonly misdiagnosed as asthma, leading to excessive healthcare use. Diagnosis is initially made by visualization of the abnormal vocal cord adduction during laryngoscopy, and it may also be diagnosed if spirometry happens to capture a flat inspiratory limb on a flow volume loop. And so if you guys are wondering if that means what that means, you can see what does D on these flow volume loops represent. They really, really like this one, but this flat inspiratory thing right here, just if you see this flat loop here, this is a fixed upper airway obstruction, basically. This is normal here. This one here has some problem with expiration. So, so vocal cord dysfunction they put here actually. So let's see. It may also be diagnosed if spirometry happens to capture a flat inspiratory limb on the flow volume loop. Oh, so is this the inspiratory limb down here? Yeah, this is the inspiratory limb down here. Sorry, I messed that up. The inspiratory limb is on the bottom. Expiratory is down here. So this is the flat inspiratory limb that they're talking about. Let me just confirm that. Yeah, I mean, if you look here, it's a variable extrathoracic obstruction, like here, and inspiration's on the bottom. So, yep, that's a nice review of that. All right, a few more questions, you guys. A 48-year-old man is hospitalized with new onset right hemiparesis and difficulty speaking. He was last well 20 hours earlier. He is given aspirin. Which of the following is the most appropriate next step in treatment? Atorvastatin, stenting, methylphenidate, and warfarin. He's probably still a candidate for stenting because it's within the last 24 hours. So let's see. His blood pressure is normal. His pulse rate is 72 and 12. Respiratory rate is 12. He has aphasia. He has all these deficits everywhere. CT scan of the head shows a hypodensity in the left frontal and parietal lobes. And a CT angio shows internal carotid arteries that are patent and an 80% stenosis of the left middle cerebral artery. I think he may be a candidate for intracranial stenting. It's basically if there's greater than 70% stenosis per this NASET trial. He should also get atorvastatin for sure. I don't see any reason he would need to get methylphenidate or warfarin, but I think he's still in the window of 24 hours to get intracranial stenting. And I am wrong. He needs atorvastatin. It's probably just carotid stenting is actually, I think that's the part that I got wrong because this is like deep. This is the middle cerebral artery. I don't think they might not be able to stent up there. Data has shown that stenting in patients with symptomatic intracranial atherosclerotic disease is associated with a nearly twofold higher risk of stroke when compared with best medical therapy. Therefore, stenting is not routinely recommended or indicated for patients with intracranial atherosclerosis. I see. I did not know that, but there's this other trial, the NASET trial, which showed that symptomatic treatments, patients with greater than 70% stenosis should be treated with surgery. But I think this is for carotid, like carotid endarterectomy. So, I guess the thing I need to learn from this one is that, stenting the middle cerebral artery or intracranial, because, the carotid artery, I'm assuming is not intracranial, right? So that's probably what the trial I'm referring to was looking at. You would have chosen B2? Yeah. I thought it would have stented, but it makes sense. I think if it was carotid, it still would be some kind of surgical thing. But yeah, if it's intracranial, then you don't stent it. A 35. So let's make a quick Anki card. Usually I like to make Anki cards on things that I got wrong. Although these two that I got wrong earlier, I feel like were basically just, unlucky. Didn't really need to get wrong. But this one, it was actually like a bit of a knowledge gap for me. So sometimes I just add a card really quick. Should a patient with 80% stenosis of left MCA undergo intracranial stenting? And the answer is no. So, and then I'll just add some details here. Medical management is recommended. Data have shown that stenting symptomatic intracranial atherosclerosis is associated with a twofold higher risk of stroke compared to best medical therapy. All right, and then make a simple card. That answer. This will make sure that I always remember this for the future. And I'll always remember, I got that question wrong where, I thought stenting was needed, but maybe I was just confused with the carotids, which, we should be able to intervene on. And it's such a simple answer. It's a yes or no question. So it's very clear to me when I'm reviewing that card later, if I got that question right or not. And then if I should mark it as good or again, or, if I need to improve the card later at some point. All right, so this person has IBS. Just looking at the answer questions here, answer options here. So a 35-year-old man is evaluated for a 1-year history of near daily postprandial diarrhea, episodic abdominal cramping relieved with bowel movement, and abdominal bloating. Which of the following is the most appropriate treatment? Alocitron. I really don't know what that is. Sounds like ondansetron. Is it another one of those like antiemetics? Linaclotide is Linzess. It's good for people with IBS diarrhea subtype, I believe. Or is it constipation subtype? I think it's diarrhea subtype, but I'm not sure. Hey, yo, Suppy, I enjoy your new doctor content as much or more than the old SC2 stuff. Oh man, thank you, Dougie. I really appreciate that. Yeah, I'm definitely looking forward to making more stuff. I've definitely been having fun doing this, so I really appreciate you saying that. Ahmed says, can I ask a stupid question? Isn't 24 hours period a bit too much? I mean, the damage is most likely irreversible after a couple hours because neurons are very sensitive to hypoxemia. Yes, you're correct. So for giving somebody TPA for a stroke, there is a pretty strict cutoff of 4.5 hours. They say 3 hours ideally, but then like 4.5 hours, they can still consider giving TPA. But if they have, if they're going in for like a mechanical end arterectomy and like clearing out clots from their carotid artery, there's actually a 24-hour window for that. Yeah. So time window for mechanical thrombectomy is 24 hours within the last known baseline, usually for large artery occlusion within the proximal anterior circulation. So when it's saying proximal anterior circulation, I'm assuming it's talking about the carotids, like I was mentioning before. All right, low FODMAP diet is always a good option for patients with IBS. And then lubiprostone, I forget exactly. I've seen it being used for patients with IBS, but it's not one I very commonly see. His only medication is loperamide. This treatment has not been consistently effective in reducing diarrhea symptoms. Yeah, so I think linaclotide is probably for IBS constipation subtype. Linzess, that one, I think, I can never remember. I usually have to look it up, but I don't see any problem with him trying a low FODMAP diet. Like, I think the reason they're going to say linaclotide is not correct is because it's probably the one that's for diarrhea subtype. For constipation subtype, and this patient has diarrhea subtype. So I think I just remembered that wrong, but I'm going to do low FODMAP diet. And then, we can even look if I have this. I'll go to up to date real quick. Yeah. IBS with constipation. I've been having sciatica when sitting down lately, and my doctor wants an MRI, but my insurance won't cover it unless I do 6 weeks of PT. I am so disgusted with insurance. Just gonna pay for MRI. Yeah. I hate insurance too. It's so annoying when we want to order something for a patient and then it gets denied. And then honestly, we have no clue how insurance works as physicians because everybody has like a different insurance and all the things that are covered and are not covered are completely different. And so it really sucks sometimes when we order something for somebody and then we see them like 3 months later and we're like, hey, how come you didn't get this done? And they're like, oh yeah, well, they said it was gonna be like $3,000. And we're like, oh man, that's just like so dumb. Yeah. I will say though that, doing PT, if they offer you PT and you have time to do it, it's not, PT does help with a lot of things. So it's not, I don't think it's like a bad idea to try it out and see if it helps you. Especially if the cost is like very, very cost prohibitive for doing the MRI. It does suck that you'll have to wait like 6 weeks, but yeah, that's just unfortunate. All right, so for IBS, a low FODMAP diet is most appropriate treatment for this patient. FODMAPs, I pay $610 for health insurance. The MRI is only $600. Why do I even have insurance? Yeah, that is pretty stupid. Yeah, okay, that does seem more reasonable. I mean, like, not reasonable, but I mean like, at least it's like you are able to afford it out of pocket, it sounds like. Because like sometimes we order these things and it's like $3,000 and I'm like, oh my God. Like I really want this patient to get this echo and it's like thousands of dollars. So anyways, low FODMAP diet, IBS, he has IBS diarrhea predominant syndrome. And FODMAPs consist of short-chain carbohydrates that are poorly absorbed and rapidly fermented by gut bacteria, resulting in the production of gas and an increased osmotic fluid load within the gut lumen. So that's why having the low FODMAPs diet is very helpful. Alozatron is a serotonin 3 receptor agonist approved by the FDA for IBS-D in women aged 18 or older. However, there's risk of adverse events, including constipation and ischemic colitis. And again, this is IBS-D. Linaclotide is for treatment of IBS-C. And lubiprostone is a peripherally acting chloride channel activator, also for IBS-C. Nice. Yeah, good. Physical therapy is all about like patient motivation too. Like you gotta have motivated patients who are willing to complete the sessions and like do everything possible to rehab as much as possible. All right, last question here. A 51-year-old woman underwent CT scan of the abdomen following a motor vehicle accident. Lab studies show a cortisol level following a 1 milligram overnight dexamethasone suppression test of 8. Plasmin aldosterone renin ratio of 13 and plasma activated metanephrines of 32. So this patient have a pheochromocytoma. Yeah. Patient is perimenopausal and has been experiencing sweating and hot flushes. They have a 2.5 centimeter right adrenal mass. This person has pheochromocytoma. Do they? Let's see. That's what they're asking. Oh no. Okay, the metanephrines are normal. The normal range is less than 57 and they're 32. Yeah, so maybe they have a hyperaldo. I don't think subclinical Cushing is a thing. It does seem to be hormone secreting. I think this aldosterone renin ratio is really high. And she has hypertension diagnosed 2 years ago. Yeah, I'm going to go with primary aldosteronism. I'm wrong. I got 60% correct, you guys, so bad. But 2 of those questions were inaccurate, so it must have been more 70. I didn't know I got so many questions wrong. What? Oh, well, I got 4 questions wrong. Yeah, so I got 80%. 80% correct. Subclinical Cushing syndrome. What? What the heck? I guess because they did this dexamethasone suppression test and the cortisol was still 8, it probably should be like undetectable or something. All patients with incidental adrenal mass should be screened for subclinical Cushing syndrome, condition characterized by ACTH independent cortisol secretion. A overnight dexamethasone suppression test should show a cortisol level less than 5. So primary aldosteronism is based on a aldosterone renin ratio of greater than 20. So what is the cutoff of aldosterone renin ratio for primary hyperaldosteronism? Greater than 20-1. And then this is another thing that I'll up to date because sometimes I want to confirm that this is right. So where is it? PAC to PRA ratio. The mean value is 4 to 10. So we can edit that card. Mean value for patients with essential hypertension is 4 to 10. Greater than 30 to 50 is average ratio in patients with primary hyperaldosteronism. So I didn't know these ratios. in general, a PAC ratio greater than 20 is considered suspicious. So yeah. They said she had stria and fat pad. I thought they said she has no stria and fat pad. See, there are no supraclavicular fat pads or abdominal striae. So that's another reason that I was less likely, leaning towards Cushing syndrome. But also this is subclinical Cushing syndrome. So that's why she doesn't have those findings. So the other card I can make here should be what should cortisol sometimes it's hard to come up with the ideal wording for coming up with an Anki card, but what cortisol level should cortisol level be after dexamethasone suppression test? Less than 5 milligrams per deciliter. On 1 milligram dexamethasone suppression test for Cushing's syndrome. If greater than 5, then 8 milligram dexamethasone suppression test. ACTH, DHES. And urine-free cortisol should be ordered. And then I probably have some other stuff. And so all incidental adrenalomas should be evaluated for Cushing's and pheochromocytoma. You only have to evaluate for hyperaldo if the clinical picture correlates, such as resistant hypertension, hypokalemia, and hypernatremia. Hypercortisolism is started with a 1 milligram dexamethasone suppression test, and then you go to 8 milligram confirmatory test and urine-free cortisol. And then pheochromocytoma, you should always get the serum or urine metanephrines. The plasma metanephrines are more sensitive, but the urine metanephrines may be more specific. All right, so we made those two flashcards. And that is it for today. So not quite as good on this one, but again, I think we got 80% on this second 10 question order quiz set. So overall, not too bad. And I think that's going to be it for this stream. Almost a 2-hour stream. And we did some Anki. We reviewed some of those old questions that got cut off on my last recording. And then finished quite a bit more questions. And hopefully you guys enjoyed this. Hopefully it was useful. I definitely have fun interacting with you guys in the chat. So thank you guys for watching again and tuning in, especially Ahmed. I know you tuned in for both of these. So thanks for stopping by. Dr. Conan, they say that pathology residents' knowledge peaks very quickly once they start, and the knowledge curve grows exponentially and quickly. Is it the same for internal medicine? Just wondering. Thank you, DFan. Thank you, Dallas. So what do you mean that the knowledge peaks very quickly and then grows? Because if it peaks, that's suggesting that it's the highest it's ever been. But no, I think it's the same for all residents. It's literally just an exponential curve. And then I think once you become an attending, you probably slow down a little bit because you're working literally half as much. And then also you're probably starting to focus on other things at that point. So I do think the highest growth rate of your knowledge is in residency, and then attending wise, it slows down a little bit depending on who you are. Hopefully for me, I'm hoping to try and keep up on my knowledge as much as possible. So I'll try and keeping that exponential curve going up, but we'll see. But definitely during residency, you're learning a ton. DFan, thanks so much for doing this. Fun to do questions with other people. Love hearing your thinking. Yeah, thank you, DFan. And thank you, iCannon Kid and Dougie Doe. Hope your sciatica does better. Yeah, really appreciate all you guys tuning in, and thanks for stopping by. I'll see you guys in the next stream. Have a good rest of your day, and yep, I'll see you next time. Peace.